We're on the cusp of the most exciting era for community health centers since the excitement that attended their very beginning. First, because of the greatly expanded diversity of our population that's coming, particularly for the populations that we help to take care of. Secondly, because of the Affordable Care Act and the role within it for a greatly expanded task for community health centers, as well as all of the changes in the way the whole health system works. And finally, here we come to the excitement and back to the future, the fact that we are at last able to rediscover the social determinants of health and get back to the second part of our responsibility, which is taking care of and intervening in the factors that affect the health of our populations, as well as the health of the individual patients that we see. If one looks back at the initial grants and the early publications of the first 5 or 6 community health centers, the ones funded initially within the first 3 or 4 years by the Office of Economic Opportunity, the War on Poverty, the framework at the time was maximum feasible participation of the poor. That fundamental vision has never changed and never been lost. That we're here to tend to the needs jointly with the people whose needs we are meeting, and that we are going to do everything and empower medically, socially, clinically, politically. We do voter registration, nonpartisan, but an effective statement of the regard in which we hold our patients and their populations. That's remained constant. And as long as we keep hanging on to that, I think we'll be in good shape. The demographic change, substantial growth of minorities, particularly Hispanic, some growth in Asian and African American populations, an inevitable shift in political power relationships, and the aging of the white population, no longer a majority, that makes them increasingly vulnerable because of age and the need for geriatric care and the increased risks that population is going to be facing medically. We community health centers, I think, are already in a variety of ways addressing those needs. You look at the demographic breakdown of the populations that we now serve, heavily minority, heavily lower income. I think interestingly, and I think Massachusetts gives us a clue to what may be going to happen, that our socioeconomic spread among patients is going to broaden. What happened in Massachusetts with an approximation of universal coverage, that all sorts of newly health insured people discovered that they couldn't get a primary care doctor's appointment in anything less than 6 months, and started, or more, or not accessible for other reasons, and started coming to community health centers. We have from the beginning been available to everybody, but the priority coming through our doors has always been people in need, people with limited or constrained access for a whole variety of reasons, and people with no resources at all, who in this one segment of our entire healthcare system can be assured that they will never be turned away or get care that's any different from the care given to those who are covered. We are doing the things that we need to do, I think, by expanding what can be called our satellite operations, misleading phrase, all of those points of service that we spread out so that one health center may be taking care of people at as many as 16 different sites to different parts of the population. We're going to have to do more of that. And we're going to have to explore ways to improve the kinds of standard approaches that we've been taking. The whole proposal in the Northwest to revamp migrant health services and find new ways to address both individual patient health and population health and social determinants of health for that very much at-risk group from both sets of factors is the kind of thinking that needs to go on for every component of the populations we serve to see how we can do that better. And it's an old dilemma, but we can solve it, I think. Beyond creativity and innovation, that's probably going to require some upfront money, but it is going to save enormous amounts of money on the other end of the operation. And that's a problem that we have fought for before, and we're going to have to do that again. From the very beginning, this whole enterprise has been a mission. This whole enterprise started with a vision that everyone in this society deserves and needs dignified, decent, affordable, real access to health care. But more than that, and all of it under one roof, and all of it tailored to the needs of people who don't have the resources to run all over town with their small children in order to put together some approximation of health care. A mission that says more loudly than any political rhetoric that this is what people are entitled to, are participant in, and have the same right to as everybody else in the society. Health centers need to remind themselves of that. We started essentially in the civil rights movement and in the war on poverty. Poverty hasn't gone away. Civil rights problems haven't gone away. We still face both of those struggles, and we are part of the answer to it, and it is part of our parentage. We need to find ways to remind people of that. My eyesight is well along in the process of disappearing, but even if the eyesight is gone, it's possible to hang on to the vision that has inspired a lifetime of work.